So our next presenters will be sharing in the process and in some cases the outcomes of 3 regional initiatives designed to increase the uptake of HPV vaccine. So I think we have a really great variety of different initiatives, and I'm hoping that all of us will learn something that we can apply in our own areas. As we heard today, HPV is still the vaccine with the lowest uptake, whereas with many vaccines, we have upwards of 80% coverage, and HPV is still sitting at about 2/3, between 65 and 70%. So we really have a lot of work to do to get that up to par with the other vaccines. So first of all, I'd like to introduce Dr. Hanna Mijovic, who's an infectious disease pediatrician at the BC Children's Hospital, who has an interest in qualitative health research and how it can help inform patient care. Hanna?
Thank you, and I'm very fortunate to be working with an enthusiastic team at the Vaccine Evaluation Center, most of whom are here today. So what do various people involved in getting vaccine in grade 6 think about school vaccination days? So I will talk to you about early findings from a qualitative study that we are currently doing in elementary schools in Interior, Northern, and Vancouver Coastal Health, and hopefully contribute to the discussion about how HPV vaccine uptake can be further improved through school vaccine programs that we have in place. So we are part of a multi-site study happening in a few other provinces and territories in Canada. And in BC, we're doing the study in 8 elementary schools, 7 public and 1 private. And we've included schools with below, at, or above average HPV vaccine uptake, variety of demographics and healthcare settings. And I would specifically like to acknowledge BCIC for funding us to expand the study beyond just Vancouver and cover some of, look into some of these differences that exist across BC. So from the adults who participate in the phone interviews, I would just like to highlight that, perhaps not surprisingly, most parents who sign up to participate in the study are parents who also consented for their child to receive the HPV vaccine, which, however, does not imply that they did not have questions or that they did not look through many information sources before they made the decision, and I will get to that in the results section. And we've had a really enthusiastic response from students so far, and the focus groups are ongoing across BC. So just as a brief background on how school vaccination days are planned for and take place. So students are eligible for, of course, 2 doses of HPV vaccine in grade 6, but they are also able to get other catch-up vaccines. So that includes varicella, hepatitis B, and depending on the health authority, other vaccines if they have not yet received them. So grade 6 is not just about HPV. And the planning, of course, happens at the school board level, and then by September, usually the school nurse would coordinate the timing directly with the school administration. And then students get a consent form that, of course, has a checkbox where parents can either accept or decline the vaccine that's distributed by either the school immunization nurse or teachers. And then they also receive a flyer about grade 6 vaccines in BC, and usually a separate flyer about HPV that's available in a couple of languages. And then consent forms are collected, again, by nurses or teachers. Nurses usually do follow-up phone calls if the consent forms are not received. And then hopefully the school vaccination day goes very well and everyone is as smiley as on these photos. With the follow-up opportunity usually available in grade 9, where, as you've heard, students can provide mature minor consent if they do not have parental signature to receive the vaccine. So onto the results a bit. So what I really like about this study is that we are kind of able to juxtapose what different groups are saying around the same issues. And I will just highlight a couple of things that have come up. So everyone had a lot to say about consent forms and information sheets. And the main thing was that parents get a lot of forms that they have to sign and return, not necessarily related to vaccinations, and that can be somewhat overwhelming. And what the school staff have observed, that students who usually have problems bringing back the vaccine forms are students who have problems bringing back forms in general. And these, somewhat not surprisingly, are students from low-income families because parents are busy. Students where parents are separated, so you might get the form home when you are with mom, but you have to return it when you are with dad. And students whose parents don't speak English. And another thing I thought was really nice was talking to students about what's in the forms. So regardless of whether your parents consent or not, it is probably important for students to know what they're bringing home. So when students have that information, then suddenly there's the push to the parents to not be apathetic. It's amazing to see how it empowers these 11-year-old children to actually go and have a voice at home and say, no, I have to have this back at school. I'm a pediatrician, I want to know what students have to say. So school vaccine day itself, you can imagine that especially in larger schools, it can be a big logistical undertaking. So a lot of it focuses on managing students' fears and anxieties. And certainly what we've heard from the school staff, parents, students, and nurses was that having a nurse that has a relationship with the school, knows the students, knows the teachers, helps not just with the logistics, but also with making students feel comfortable. Students had a lot to tell us about what they thought about the vaccine day. One thing that they did make loud and clear is that they don't like surprises. So my nurse said she would count to 10, but I got a shot when she was at 3. We got to play volleyball afterwards, but our arms were sore, so students didn't like it, and all the teachers and parents at the same school who we interviewed separately thought it was a great idea because it made them forget about the pain. Having a therapy dog would help, so take note. And I also have to say that there was a lot of very positive comments from students about the experience. I have autism. I was really worried about getting the shots, and it actually went well. So it's not even true that vaccines cause autism, this grade 6 boy told us. And students are curious about vaccines. So they bring the consent form home, and they said, it would be nice to know what all those letters like Tdap, HPV, MMR actually stand for. So how about HPV itself? Parents definitely go look at other sources, not just that information flyer that comes in the consent package. Parents talk to each other, and a lot of parents mention talking to their family doctors. And I'll read this quote because it illustrates a few issues. It's from a father who said, I was diagnosed with cancer related to HPV virus, and it made it real. And a lot of our friends, well, not a lot, but there was a couple of them that weren't going to do the HPV for their boys because they didn't believe their boys could get it. It was a girl's virus. So I'm a walking, living proof that no, boys can get it too, and their kids got vaccinated because I got sick. So a common perception that a few parents have voiced that it's seen as a vaccine for girls, and parents talk to each other when they make those decisions. So students generally knew it prevented cancer. They may or may not have linked it with sexual transmission, and generally felt that it should be something that they talk about, some of them with parents, but usually in schools, both about the cancer part, but also about the sexual transmission part at what they told me was grade 6 appropriate level. Nurses may or may not have HPV vaccine-specific training, so the vaccine has been around for quite some time now. School staff generally did not know a lot about HPV vaccine. They saw it as another vaccine in the schedule. They usually, from the ones we talked to, weren't aware that the vaccine has been introduced for boys. And across the board, school staff were under the impression that their schools had high uptake rates for vaccines in general, including but not limited to HPV. This would be an example of what we heard regardless of what the uptake was in the school. So I think we're pretty high. I know there was a couple of children, I believe there were 2 families whose children hadn't been vaccinated. But other than that, I think our rates are fairly high, and this happens to be from a school that actually has below average uptake. And finally, so who should talk to students about vaccines? But it's important. It's vaccines that happen in grade 6. So parents, at least parents we spoke to who generally support vaccines, felt that schools have a role to play. Sometimes students pay more attention in school than they do at home. schools didn't necessarily include vaccine discussions in the curriculum. I think the Kids Boost Immunity came up with one of the schools, but teachers in general were not aware of it in the schools that we spoke to. And what we heard from all schools was the difficulty of walking that fine line between teaching about vaccines and therefore at least indirectly endorsing them, knowing that the decision to vaccinate or getting the vaccine through the school program still lies with parents, and wondering whether that might, in some circumstances, create a difficult situation at home. And students wanted to talk about vaccines, a lot of emphasis on you need to know what's going on in your body. And students love science, and like we've heard from a few people, there is a science curriculum in grade 6, so maybe just leaving you with this quote, is there more room to talk about vaccines as part of a science curriculum in schools? So some preliminary thoughts on what's going well. Clearly a big logistical undertaking. Kudos to all the nurses who build those relationships with schools and make this a better experience for students. Based on what we've heard so far, I feel that we probably have some great resources like Kids Boost Immunity or iBoost Immunity, as well as immunization dashboards with rates for individual schools that could be made available to teachers and parents. So these resources are there. Perhaps they're not as well utilized as they could be. In terms of what we can do better, engage everyone in the discussion, part of the reason why we're doing this study. And I think if I could pick one thing, I would probably focus on streamlining the consent process so that the forms are easier to return, perhaps in an electronic form. Not sure what to do with information for parents. More information, less information, probably something that's more easier to navigate and more targeted to what an individual parent would like to know. And with that, I'll turn it over to you. So what do you think about shots in grade 6?
Thank you, Hannah. Next, I would like to, and the panel will all be available for questions at the end, so please, you can jot down your questions or enter them into Slido, but we'll have time for questions after. So next, I'd like to introduce Dr. Mina Dewar, who's a medical health officer for Richmond within the Vancouver Coastal Health, where she supports a number of program areas, including immunization.
Hi, everybody. Good afternoon. So thanks for inviting me today to share on behalf of our Vancouver Coastal Health team our experience in addressing and improving HPV coverage in Vancouver Coastal. And in the next 10 to 12 minutes, I'll share with you all the strategies we've tried and the one that really works. So to some level, we've explored these, and the ones with the stars are the ones that really make a big difference. Grade 6, and Hannah has shared with you a really great outline of the grade 6 program. We offer vaccine in grade 6. The baseline acceptance of this vaccine as compared to that of other vaccines is a huge determinant of the rates. In Vancouver Coastal, we actively consent and re-offer in school to grade 9 students, and that is the best strategy that we have determined and that I recommend to all of you. We've also determined that the number of doses in a series, and the fewer the doses there are, the easier it is to improve coverage, really works. The number of clinics in grade 9 that we offer is really important. We've also fiddled around the edges to see if closing off series in grade 10, which is important from an individual level, whether it helps get us to the 90% coverage target. We've piloted a grade 12 catch-up, as well as in-class education. So just as a reminder, the HPV vaccine schedule in BC has simplified over time. We started with 3-dose series in 2008. We went to an extended dose in 2013 or so, and then we went to 2-dose series in 2014. And I bring your attention to the 2013-2014 transition year because that's important when we look at the rates. And of course, now we're at a universal program, which is super. Thank you very much to the ministry. So what I'm showing you here are HPV vaccine coverage rates over about a 10-year period for 4 different administrative areas of Vancouver Coastal, Vancouver on the far left, Richmond, Coastal Urban, and Coastal Rural. And you'll see that the rates, of course, fluctuate from year to year as is normal. In red is the Vancouver Coastal Health average, and in black is the BC average. So essentially, for grade 6 program, the acceptance in Vancouver Coastal is no different than in British Columbia. What's important to note is that Vancouver, being the largest community of care, essentially drives the Vancouver Coastal Health coverage, having about 50% of over 9,000 grade 6 children. This is, of course, girls for now, so it's half of that. Richmond leads the VCH coverage, and the other 2 communities of care dance around the VCH coverage. What we also see is a concerning decline in the coastal rural coverage over the last 2 years, which we'll keep an eye on. So, number 1, vaccine refusal versus vaccine hesitancy. I've taken a poetic license in this slide in that the 0-dose coverage is for all children, and the HPV 0-dose coverage is just for girls. So in red is the proportion of kids or parents who refuse all vaccines for their children, or at least for which we don't have documentation. Overall in Vancouver Coastal, it's about 2% of grade 6 students. But for HPV, it's 16%. So there lies challenge number 1, how to close this gap and increase HPV acceptance. And clearly you can see the challenge our nursing teams face across the communities of care, with coastal areas having a very high 0-dose HPV acceptance, or rate, pardon me. So this is our best strategy, reoffer in grade 9. This is a programmatic strategy. So what we do is we take the kids who, because we offer immunization by history at every encounter in grade 9, when we send consents out for the grade 9 target vaccines, we also in those consents include every other vaccine that they may have missed and they're still eligible for. And that helps us improve coverage by about 10%. So in red, again, is the VCH coverage, and you'll see that it's at about 80%. You'll remember that the grade 6 coverage was about 70%, so it automatically brings it up about 10 percentage point higher. And then the second point, in black is the provincial coverage for grade 9, and if we've missed any years for provincial coverage, forgive us, but VCH coverage is a bit higher than provincial coverage. The other point is this increase in about 10% that occurred between the 13 and the 13-14 school year, which is somewhat coincidental with that extended dose that came in, so an extra opportunity for immunization, and then continued after that because we went from 3 doses to 2-dose series. That's my story, and that's, I'm sticking to it. And so if we can go down to 1 dose, that's even better. So my next point is, again, you'll see that Vancouver drives the coverage. Richmond did really well last year. Thank you very much, folks. We hope it continues. Coastal Rurals in grade 9 is doing well. And then all is not the same in all communities of care, so there's a gap in coastal urban that we and our teams are very aware of, and we're addressing it. And I'll talk about why that gap is in the next slide. Oh, and of course, there's a 90% target, which is a national target for age 17, but we've brought it down to grade 9 graduates for our program. So that's the same information for grade 6 and grade 9, organized by birth cohorts, essentially to show that we do get that increase in coverage from grade 6 to 9. And the denominator is about the same. It goes up, actually, in grade 9. So my next point is that if we're going to reoffer in grade 9, which I think is extremely important, and we all should consider it, the 1-dose coverage, so the ultimate coverage varies by how many clinics we offer. So if we're going to start a series in grade 9, we have to be able to complete it in school in grade 9 to have the best outcomes. So you'll see data for 2016-2017 school year, and so the reason this came to our attention is because of this. Richmond coverage dropped to 73%, which was a big shocker for us. And when we looked further, we saw that the one-dose coverage was 20%. And that was primarily because of a programmatic decision to go from 2 clinics to 1 clinic, which resulted in that drop in coverage. We also noticed, of course, the other community of care that had that gap between VCH and their coverage only offers 1 clinic in grade 9. So we've been able to address that, at least in Richmond. Extra work has been done in Richmond to get back to 2 clinics in school, so thank you very much. And the one-dose coverage for subsequent year went down to 13% and has carried on going down further. So please offer in grade 9, and please try to get 2 clinics if at all possible. I was asked about grade 10 coverage because our nurses do actively, when they're immunizing kids in grade 9, they will close off series for grade 10 students who may have consented the previous year but didn't show up for a clinic. So I was asked, hey, why don't we report grade 10 coverage? And that was a very valid question, so we checked that. I'm only showing you data for Vancouver because it gets a bit more complicated for other communities, but the bottom line is that our 2-dose coverage for grade 10 went up 2 percentage points, which again is very important from an individual protection in closing off series, but it doesn't help us get to the 90% that we're trying to get to. And the reason this happens, of course, is because there's a whole bunch of kids, new kids coming into grade 10 who we're not seeking out with consent for immunization. So our denominator expands in grade 10. Okay, so next. Well, if offering in grade 9 works, how about offer it in grade 12? And for this pilot, I want to thank our brave nurses in Vancouver who tried this. Thank you very much. I know some of you are in the room, who worked with 3 high schools in Vancouver to offer a grade 12 HPV campaign. And the baseline coverage in that high school was 74%. They identified about 117 girls who were still eligible. Most of them were new, and consented them and offered a series, and the final coverage went up to 78%. So from 74 to 78%. We did reach another absolute 12% of the grade 12 cohort who consented to be immunized, but it was hard to get them immunized in a timely fashion and in school. So our coverage could have been as high as 86% if everybody showed up to be immunized after they consented. The other piece, I'll just take a sidetrack. The other new learning for us was that 3 out of 4 interested students who consented to be immunized were actually new students. So they weren't students who missed it in grade 9. Only one out of 4 who missed it in grade 9 consented to be immunized in grade 12. The rest were all new gals. And that's all good too. So we determined, while this is a great idea, we need lots of money to make this happen. There's a whole influx of new students in grade 12. You move to a 3-dose series, so you need 3 clinics in school, which is, if 2 is painful, try 3. And finding grade 12 students for clinics gets very difficult because they're busy doing lots of activities. So not where we want to go. And then the final pilot that I want to share with you is what about in-class education to try to promote the vaccine and increase awareness of the vaccine. So this was tried by our nurses in coastal rural in 2015-2016. They offered 2 in-class sessions to their grade 5-6 girls, plus referred them to iBoost Immunity website. Kids Boost Immunity was not around at the time. Pilot school was Squamish Elementary. We have a pre-post analysis for what it's worth. The coverage was 77%. Pre-pilot went up to 89%, but the confidence intervals are overlapping because, of course, it's a small school. But there was no increase in coverage in other schools in the area in the post-pilot season. So it looked like it was a good way to go, and promotion and education is always a good way to go. But what's important is when you look at the coverage for those schools for a number of years, which we have, it kind of bounces all over the place because of the small numbers and the cohort effect. So was it really the education, or was it just a cohort effect? So education is always an important strategy to consider, but needs further evaluation, particularly with the new curriculum, and of course it's time intensive, but we will definitely consider it in schools with low coverage. And we need data to support local action, which we have for schools in Vancouver Coastal, thanks to our surveillance unit. So what we're doing now is for this current school year, we will evaluate the passive strategy that we have in place, in which we are sending out personalized immunization notices to about 30% of our 130,000 students in Vancouver Coastal to try to catch them up. And we will look to see whether this passive strategy and outreach to girls in grades 7 to 12 resulted in an improvement in HPV coverage or not. We also had funding through BCIC, so thank you very much, BCIC, for an active grade 7 campaign. And so we'll see where we go with that and whether it'll help us get closer to that 90% for grade 9. So the bottom line is, got to focus on the grade 9 campaign. And this was our vision for not the current school year, but the previous school year, before we were sidetracked by the measles campaign. What we want to do is increase opportunities to close series for the 10% of grade 9 graduates who have received 1 dose. That's the low-hanging fruit. These are the folks who have consented to be immunized, but for one reason or another, we haven't been able to close their series in a timely fashion. So we need to start grade 9 clinics September to December so that they're still eligible for 2 doses, because girls and boys start turning 15 in January. So we want to get them started before they start turning 15. Starting clinics September to December becomes difficult because we're also trying to start our grade 6 clinics at the same time. But we're trying to work around that. The other strategy, of course, was the active follow-up of 1-dose recipients near the end of the school year before we count our coverage. So we'll do our best to get back to it. And of course, promote vaccine in low-coverage school areas with Kids Boost Immunity. And thanks very much for that curriculum. So that's where I'll stop. And of course, I want to thank our superb group of program administrative staff, immunizers, and nurse leaders who really get out there to reach every single kid every single time. And our amazing surveillance team, without whom we really couldn't be doing this. So thank you very much.
Thank you, Mina. And last but not least, we have Jenny Nyhoff and Sari Racy. Jenny is a public health nurse on Vancouver Island, and together with Sari Racy, who's a postdoctoral research fellow at the UBC, they are doing a really innovative project using motivational interviewing with parents around and to increase HPV immunization. So over to the two of you.
Excellent. So thank you so much. Thanks for the invitation to be able to present on our project today. And it's my absolute pleasure to be presenting alongside Jenny on behalf of the entire team, many of whom are sitting in the room and who are joining us on the live broadcast.
They even sent a photo that they're having a super time.
There we go. Okay, so as we've heard from many previous presentations today, that rates of HPV vaccine in BC are lower than we would like, and it varies across jurisdictions. So one of the lowest rates of vaccination in the province is actually in the north of Vancouver Island. And so looking at this area, we also looked at comparative rates of other vaccines that are offered during grade 6 and to see that their vaccine coverage is actually really high. So indicating that, as we've heard, there's something special about the HPV vaccine. So given the sort of gold standard of the BC immunization program, it's offered in schools, we have universal consent and personalized consent, what else could we try? And so as was alluded to in previous presentations, we can look to the literature, and it suggests that having a conversation with a trusted healthcare provider is really key for parents to consent to the HPV vaccine for their children. The slides are a little funny, but we'll keep moving. So the main aim of this project was to leverage and engage local public health nurses to help increase the uptake of HPV vaccine in the grade 6 program. And this was done using the implementation of a tailored messaging intervention. And so the tailored messaging intervention was augmented through the skills of motivational interviewing. So what did this intervention look like? So for parents of grade 6 students who did not consent to the HPV vaccine on that school immunization consent form that we got to see just a few minutes ago, they were identified and they were flagged as being eligible to receive a phone call from a public health nurse. And so these were parents who had consented to vaccines in the past. And so really we were looking at those vaccine hesitant parents, and we were not including parents who had refused all vaccines. So I think it's important to think about who we were targeting with this intervention. And ideally, we were looking for parents who were kind of ambivalent. So thinking of that great slide in terms of the scale from vaccine acceptance to vaccine refusers, looking at that 30% who were vaccine hesitant. And so we've heard a lot about different communication styles and approaches, so thinking about our earlier presentations around rhetoric and persuasion, fear-based, and also thinking of sort of mass social media campaigns. And so I'm going to turn it over to Jenny, who's going to give us a very brief primer on motivational interviewing and how we used it in the context of talking to vaccine-hesitant parents.
All right. Thank you, Sari. So I'm thinking that everyone here is at a different stage in your journey of understanding motivational interviewing. Some may be just introduced to it today along with me, and others may be utilizing it in your daily practice. Members of our team are also on their own journeys. However, at the start, we had all had the Foundations of Motivational Interviewing certificate course through CCMI, who are the leaders in motivational interviewing training in BC. I want to start by acknowledging the founders of motivational interviewing, William Miller and Stephen Rolnick, and their working definition. That would be really helpful if I put that up there. Motivational interviewing is a collaborative conversation style for strengthening a person's own motivation and commitment to change. So here we have a very quick MI theory overview in 2 minutes. It looks like a busy slide, and it really is. And motivational interviewing is a complex communication style that has a lot of evidence, and those who are committed to it spend intentional practice and feedback on their journey to it being a way of being when discussing ambivalence with folks. So let me break this down a little bit for you. In the center there, we have the arrow, and those are the skills of motivational interviewing. We call them our ORs. Open-ended questions, affirmations, reflections, and summaries. And these are used to intentionally invite a conversation to go deeper into the thoughts and feelings about ambivalence a person is facing in order to increase their confidence and motivation for change, and to enhance our therapeutic relationship. An example which the nurses used to open with in a conversation when they called was something like, "Can you share with me what led you to say no to HPV vaccine for your child at this time?" That's an open-ended question to evoke and find common ground, as Dr. Diekma talked about earlier. This is very important, and it was a change from our previous practice in making audit calls, where we would phone and remind parents about what their child was due for and invite them to make an appointment, but didn't encourage engagement in a supportive conversation. So we use these ORs within the 4 processes of motivational interviewing: engaging, focusing, evoking, and planning. It looks like a stepped approach to care, but however, we do go up and down and back and forth within conversations in these processes. And the end result is not necessarily a plan. When we're asked for advice, because we use skills called ask, tell, ask, or elicit, provide, elicit, which is a respectful way to explore an issue and evoke mutual understanding. And finally, the CAPE. The CAPE, or PACE. So while we practice the skills and processes, it is fundamentally important to keep the spirit of motivational interviewing. This is the attitude that helps us be patient-centered, maintain curiosity, be empathetic, and to allow people the autonomy to make their own decisions. The spirit helps us resist the righting reflex also, where with good intentions, we feel like we need to have answers or fix people or their dilemmas. We clearly have the expertise in administering immunizations and the science behind vaccines, and parents are the experts in their children. So MI is ideally used in a relationship discussion that has some ambivalence or a willingness and open to change. It's not for those who have their definite decisions made, so that 1% that we were talking about earlier. So knowing that most parents who do not consent to HPV vaccine on their consent are hesitant and not people who are opposing vaccines, it supports MI to work as a foundation of communication with vaccine-hesitant parents. And as Kathy said when she was talking about the immunization communication tool, there is something that's supports. There are things coming, hint, hint, that will support us to work in a different way or communicate differently with using motivational interviewing in our practice around vaccines. The spirit of MI is often a very natural place for nurses to work in their practice anyways. So MI was incorporated into the project, and nurses were able to continue their MI practice and continue development in 3 ways. First, we developed a conversation guide for HPV vaccine hesitancy with the intention of telephone practice, but also within appointments as needed. The guide brought all the skills and strategies of MI together with examples, responses from statements that we had heard from parents during other previous calls that we had had with them. For example, we have suggested responses to vaccine safety, risky sexuality, behavior, and gender concerns. Like Dr. Juliette Guichon said, and Dr. Ogilvie, that promiscuity is a concern for parents. The other thing that was really helpful is Dr. Gina Ogilvie, being a part of our project, really helped us to have confidence in our responses. I'm thinking many of you may have some increased confidence by the sharing that she's done about all the great work that has been done in BC. The second thing we did was had a local workshop that's specifically about HPV vaccine hesitancy and practicing MI over the phone. Well, a lot of you are public health nurses and do more and more of your work over the phone. We hadn't had any training to date specifically about telephone care. This workshop was an opportunity to practice before we jumped in. And the anonymous feedback that we got from the participants, the nurses who participated, said that the practice time was very key and that they wished that they had had more, and that the resource binder was excellent. In addition, 7 nurses attended the Canadian Pediatric Society workshop on vaccine hesitancy right here in Vancouver on October 30th. A large emphasis there was on the spirit of motivational interviewing and the skills, and helped us continue our practice of MI in conversations with vaccine hesitancy. One of the key takeaways from that workshop was the use of presumptive statement, like the one that I have here. You're here for your HPV vaccine. What questions do you have, if any? Rather than the more traditionally asking, why they might be here, what they would like, and if they have any questions. So the presumptive statement shows confidence by the provider and may move folks to acceptance in a more timely manner. So back to you, Sari, for some of our preliminary findings.
Thanks, Jenny. So we tried this intervention. The first cycle was in the fall of 2018. And it's just to share a few sort of tidbits as we're exploring the data. So we were able to reach 90 parents who had not consented to the HPV vaccine and had telephone conversations with them. There were an additional 74 parents who had been flagged as eligible. So this was a really important finding for us in terms of what it takes to actually implement an intervention where you have to phone parents in terms of time and scheduling. We spoke to parents for students in grade 6 for both boys and girls and got feedback on both of those sort of differences in how parents were perceiving the vaccine. And one of the major findings I wanted to share today was that the majority of parents responded really positively to having a public health nurse call them and open a dialogue around the HPV vaccine, giving them an opportunity for questions and to be able to just engage with the public health nurse, given that, you know, prior in childhood vaccine, they actually went to the public health unit and they got to speak to somebody, whereas the school-based clinics, that they didn't necessarily have an opportunity to be able to have a face to their public health nurse and ask those questions. Based on the data collection so far, 20% of parents actually provided consent for the vaccine during those phone calls, and we'll continue with the analysis and confirmation looking at the immunization record. We were able to offer the intervention again in the fall of 2019, and we are currently entering that data as we speak today. So those full results are coming. So I wanted to briefly touch on next steps for this project. And I first wanted to mention just this is a wonderful example of a partnership between public health and research in being able to answer sort of clinical questions. And so it's been such a privilege to be able to work with the entire team at Public Health Nursing to be able to get their feedback and really acknowledge their expertise in this area. So we're going to be continuing to analyze the uptake data, as I mentioned. We also collected metrics on costing, so we'll be able to do a cost analysis to see what the cost benefit of phoning parents and actually what that looked like. And we also asked parents if they were willing to consent to a follow-up survey. So we have a number of parents who have provided consent. So these are going to be parents who have said no to the HPV vaccine, and we're going to be asking them some questions around their reasons for vaccine hesitancy. We'll also be developing a toolkit, so looking at our resource binder, and as Jenny alluded to, which is also an opportunity for student involvement as well. And in terms of their continued and ongoing practice with MI skills in dealing with vaccine hesitancy. So I'd like to acknowledge this is a very large team effort, and it's lots of hours and lots of thought into this project, and so important to acknowledge and thank the entire team for that.
Thank you. So we have time for a few questions. If anybody here would like to step up to the mic, I would like to invite you to do so at this time. But we do have a couple of questions online. One is regarding the duration of HPV vaccine protection. I think we've heard 10 years, and so that we know. And so one of the questions is regarding to that, do we know, when will we know if it's longer than 10 years? And how does that work with immunizing 11-year-olds or 14-year-olds who may still be at risk well into their 20s and 30s?
So thank you, that's a great question. So yeah, right now, the first vaccine studies were really started in about 2004, so the Nordic countries are doing follow-up on those. So we're getting up to sort of 12, 15 years for 3 doses, and we actually published the longest data for 2 doses, which is, as I mentioned, is about 10, 11 years. So we don't have data on lifetime protection yet. What we do have, though, are the graphs of the antibody decay, and it's pretty flat. Once you sort of hit 18 months to 24 months, it's pretty flat. So we don't anticipate a sort of precipitous drop, but we are committed to continuing to monitoring. I think the second point is that while lifetime protection would be obviously the optimal, really acquisition for HPV and the acquisition for HPV that causes cervical cancer happens in large part, before the age of sort of 35. So for women. So I just want to repeat that again. That's the acquisition. It takes long for the HPV to develop into cervical cancer, but most of the cervical cancer that develops, you've acquired it when you're younger. So yes, it would be optimal to have lifelong protection, but what we really want to do is make sure we have protection for sort of those 20, 25 years, up until sort of 35, 40. And that's reflected also in the when you think about sexual networks, the most active times, and I'm not saying people over 35 don't have sex, please don't direct message me about this. I don't want to hear about it.
Happening in the seniors' residences?
Yeah, exactly. I don't want to hear about it. But there is data that shows that the density in sexual networks, number of partners, the proximity of partners, et cetera, does decrease as you get older.
Great, thank you. Juliette?
I have a question about the decision, the decision tree. So when in the motivational interviewing, so if the parent says, no, I don't want to share with you my reasons for refusing the HPV vaccine, I'm wondering why you back off so quickly by saying that's totally fine, because it's not totally fine. So, I just would encourage you to say, well, let me please, before I get off the line, let me please explain the risks. And because I think most parents don't know that there's a risk that their grandchild will be born premature. Most grandparents, they don't know that. They don't know that it can cascade down the generations, or the risk of, which is rare, of respiratory papillomatosis. I can't even say it. But why not just leave them? And also from a legal perspective, you don't want to say, oh, that's totally fine. It isn't, right? And they may, this is rare, and it doesn't usually happen, but this is how we're trained to think. You don't want to be liable for having said that, because you can't say, before I go, I'm just going to remind you of the risks for your child and your grandchild. And then you've left them with something. And it's not a punch in the nose, it's information.
Excellent. No, thank you so much. And this is actually something we talked a lot about as a group. There's a lot of hesitation around, these are parents who have already said no. And so there was some hesitation around contacting them and what that potentially very uncomfortable conversation would be back towards the nurse, making those calls. And so one of the things that the nurses did was, for parents who said, no, I don't want to talk to you, it was, oh, no problem. Please, I want you to let you know that at any point you would like to call us, where you can contact and you'll get a public health nurse that you can speak to. We can answer any questions that you have. And they really tried to leave the door open to that conversation. But oftentimes they may not have had a chance to even say that before they heard a click. So, so I think that it's a balancing act around trying to make sure that you're maintaining that relationship.
So what about following up by letter, saying, we've had this lovely conversation today. I just wanted to follow up. These are things that you might not know, and here's our phone number.
Yeah, and I think that it's the chasing part and the resources going into that. Ideally, yes, ideally we would love to invite them for tea and to have that conversation, and I think that and I think there's an opportunity to catch them again in grade 9, as we heard, and so it's also the resource allocation part.
Okay,
Yeah.
fair enough. Thank you.
But thank you. Yeah.
Karen?
Julie, can I just say one more thing about that? I think the nurses work really hard to not just stop it there. Like, they might use something like an affirmation, not to be cheeky, but to really honor that parent's passion. So you might try to engage further when they say that, you're very passionate about making the right decision for your child. And we may just get a little more engagement, but yeah. Oh, did you hear that? Yeah.
Thanks.
Mm-hmm. Yeah, thanks, Juliet.
Okay, Karen?
Thank you. It was mentioned today that parents talk to parents, and also that we should advocate, share the knowledge that we have, and advocate at all the opportunities that we have. So I was just wondering, for those of us who aren't in the schools regularly, but are maybe parents of elementary school students, for example, if anyone's thought about strategies to get parents involved as champions, but especially parents like myself in the room who could potentially, who are knowledgeable to some extent, to either partner with public health nurses or other people and just be maybe a more familiar face to be sharing that message. No, North Shore.
I think that's a really great point. Again, don't DM me, but I often would end up what I call the conversation with the Lululemon mums. That's what I mean, where after, I drop the kids to school and there'd be sort of a group of mums sort of chatting, and I would kind of be racing off to somewhere, but I would sort of stop and chat. And that was often one of the most influential conversations with my son's hockey team, my daughter's basketball team. Like, you would just be sitting there and have these conversations. And I think what was really important was the confidence I had, and I forget who, we talked earlier, just saying with great sort of confidence that, oh yeah, no, absolutely. Oh yeah, my kids, of course they're vaccinated. And the sort of the confidence that you offer, we found in our parental survey, the most important thing was having a trusted health professional advocate or recommend, not advocate, but recommend the vaccine. And I think there's a lot that can be said about that confidence of a trusted professional.
Hi. I want to thank you for your comment. I think the key is we don't know you, but if you're interested, and other parents, or many of us are parents and interested in becoming champions within our school community, you're welcome. Please come find our public health nurses, get to know your local medical health officer, get to know your school public health nurse, because the school office will know who that is. Reach out to them and join them. I can think of, I think it was in Vancouver where we had some challenges with HPV coverage in some of our Catholic schools, and a member of the community who was an obstetrician really went out and championed the vaccine in that school community, and that did the trick. So please get to know your school coverage, get to know your school public health nurse, and become very active in the community. We invite you.
Just to follow up, I mean, I feel like this is a role. I agree with Gina's comment about at the soccer pitch or hockey rink or whatever, but also even I find through conversations that I've had with neighbors whose kids are maybe a bit older than mine who are going through this right now, it really highlights some of the different questions and some of the different reasons that I don't even think all of them are highlighted in the research that we're putting together, because there's sort of a subtle variation of some of these things, and when we know people, we can start to learn what the real reasons are, or what the maybe change the wording. Anyway, but yeah, I think it's great. Thanks.
Minish?
So thanks to all speakers for some really great presentations. I think one of the silver linings of the hesitancy is seeing all the creative solutions that people come up with to try and deal with it. So it's quite striking that the various interventions that you and others have spoken about today have great range of resource implications, both in terms of bodies on the ground, but also financial cost. So I was wondering if any of you would like to speak to any evaluations that you have done, or maybe what should be done to properly evaluate the resource implications for these. I don't know what the equivalent of a vaccine coverage quality would be, but in terms of thinking about it in that way, and for each 5% increase in coverage, what value is, I know it's almost impossible to put a dollar value on it, but that's how every other healthcare intervention is measured. So how do we measure that? And is each 5% the same? So is going from 80 to 85 the same as going from 85 to 90? So I open that to anyone who wants to answer.
So the project we're doing in North Island, one of the key things we have done has actually been, and the nurses have been great about it, I know it's been a bit of a hassle, but they've been really documenting time, sort of how much time it takes to assemble the names, to make the calls, the sort of call refusal, the call acceptance. So we will have that data, and then we can actually follow through Panorama, sort of what the outcome was. So that, it's not your sort of new sort of fangled measure, but of sort of cost per quality per vaccine day. But we will have a sense of how many hours, how many minutes, and the cost that it took to achieve what we did. So that's will be our starting point. Yeah.
I was just going to mention too that in terms of that cost analysis is also looking at how much we can actually integrate into the existing nursing practice, right? So I think it was mentioned that for any of those returned consents that are not returned, calling those parents is already something that is done. And so looking at how much more work in terms of hours does it actually cost to flag those HPV hesitant parents, or pick another vaccine in a community that you need to target, what that would look like. And I think that the nurses have provided a lot of learning opportunities in terms of how you can move around scheduling that doesn't necessarily cost a lot, but can really help improve the efficiency of an intervention like calling parents.
So I want to take that up too, because I think that it's important how panelists on my either side address vaccine hesitancy, which would address the grade 6 acceptance rate. And we in Vancouver Coastal have really addressed re-offering the vaccine at an age when youth can consent for themselves, which we find is a lot easier than trying to get parents to consent for them. We always try to get the consent from the parent, but if that doesn't happen, we do not hesitate in calling every single youth down and saying, hey, let's talk about this vaccine, and many of them do consent on their own behalf. So we certainly find that that's a lot more efficient, but I think it's worthwhile doing the cost determination, particularly for the grade 9 clinics where we need the second clinic. And I want to take this back to the differences in rates across Vancouver Coastal. And I always feel badly for our colleagues in coastal urban because it's a real capacity issue, our ability to offer extra clinics when they're not funded, and knowing how many programs have come down our path over the last decade that have been unfunded. So there's huge capacity issues in the system, so I think it's worth calculating the cost for both and seeing which is better.
Thanks.
Last question.
Yes.
Thank you for an excellent day. Not to get ahead of you, Christine, but Kids Boost Immunity was mentioned a couple of times, and thank you for doing that as well. There's talk about kids being able to consent for themselves. Of course, that's one of the ideas behind Kids Boost Immunity. If they can have that agency, they can exercise that agency. Also, kids actually being the champions. It's great if you can get parents to be the champions, but that's a harder sell. So the idea with Kids Boost is to have the kids be the vector to get to the parent. So one of the things that we've, thanks to BCSC funding, that we're just finishing our analysis now, had to do with a new set of lessons on Kids Boost, where it's how to prepare for your immunization day like a champ, how to prepare for your shots like a champ. And we've just done some analysis on it. We're just finishing it up. But suffice to say, the results are really good around if you can get the kids to try Kids Boost Immunity in that critical period just before immunization day, the week or 2 weeks before when consents are going home. What we found is that they go home and talk to the parents about it. It acts as a bit of a mnemonic for that reminder. And it also increases dialogue, reduces anxiety in the classroom. It brings down the temperature for the parents, the teachers, the kids, and public health. Also helps maybe reduce the number of times you have to follow up with those darn consent forms and stuff. So I think there's a lot of potential within public health to, ramp this up, because I'm not surprised that someone mentioned earlier that one school heard of Kids Boost Immunity. We have a long, long way to go. Getting into the education system is a completely different animal. We work in health, they work in education, and we have different reasons for being, I guess. And so one of the things that we found with this particular set of lessons is that it could potentially act as a little bit of a bridge between health and education, because for public health folks who are going in, that is their wheelhouse. It is immunization day. However, the onus is not on them to go in and teach it. The onus is on the teacher, and that's a really critical thing, because unless something has changed, I think people here are pretty busy as it is, and as our teachers. But so if we can get them to, oh, okay. If we can get them to try it at that critical period, then it could make a difference. So you'll be hearing more about it through the promotions working group, I hope, on the results, and I hope we can get into more schools next year.
That's great. Thanks, Ian, and maybe a topic for next forum. I'd like to thank our HPV experts for their very insightful presentations. I've just got 2 quick housekeeping items, and in the meantime, I'm going to invite our BCIC co-chairs, Margot and Izzy, to come up to say a few final words. And I just, on behalf of myself and Monica, just want to thank all of you for coming today, making time at a very busy time, and to all the wonderful speakers. Thank you.